Hello and welcome. Today we're diving into the world of connective tissue disease, associated interstitial lung disease, or CTD-ILD. This complex condition represents the intersection of autoimmune disorders and lung health and can significantly impact a person's quality of life. We'll explore what it is, how it develops, and what can be done about it. So, what causes CTD-ILD? Well, it's not caused by a single, easily identifiable factor. Instead, it develops as a complication of underlying autoimmune diseases. These diseases, such as rheumatoid arthritis, systemic sclerosis, also known as scleroderma, polymyositis, and dermatomyositis, are characterized by the immune system mistakenly attacking the body's own tissues. In the case of CTD-ILD, this immune system dysfunction targets the lungs. To understand CTD-ILD, we need to talk about the pathophysiology, what's actually happening inside the lungs. In these autoimmune disorders, inflammation spreads to the lung tissue. This inflammation primarily affects the interstitium, the space between the air sacs, or alveoli, and the blood vessels. Over time, this chronic inflammation leads to scarring, known as fibrosis. This fibrosis thickens the interstitium, making it harder for oxygen to pass from the air sacs into the bloodstream. This is why shortness of breath is such a common symptom. CTD-ILD's prevalence varies depending on the specific connective tissue disease. For instance, ILD is quite common in systemic sclerosis, affecting a significant proportion of patients. In rheumatoid arthritis, the prevalence is lower, but still represents a substantial number of individuals. Polymyositis and dermatomyositis also carry a risk of ILD development. While precise numbers can fluctuate across studies, it's clear that CTD-ILD is a significant complication that clinicians must be aware of. The signs and symptoms of CTD-ILD can be subtle at first, often developing gradually. The most common symptom is shortness of breath, especially with exertion. Patients may also experience a dry cough that doesn't produce phlegm. Fatigue, a general feeling of tiredness and weakness, is also frequent. Over time, as the lung disease progresses, these symptoms tend to worsen. In some cases, chest pain, clubbing of the fingers, widening and rounding of the fingertips, and weight loss can occur. Because these symptoms can overlap with other conditions, a thorough evaluation is crucial. Diagnosing CTD-ILD requires a multifaceted approach. The process typically starts with a detailed medical history and physical examination, taking into account any existing connective tissue disease diagnosis. Pulmonary function tests, which measure lung capacity and airflow, are essential. High-resolution computed tomography, or HRCT, scans of the chest provide detailed images of the lungs, allowing doctors to visualize any signs of interstitial lung disease. In some cases, a lung biopsy may be necessary to obtain a tissue sample for microscopic examination. This can help to determine the specific pattern of lung injury and rule out other possible causes. Finally, blood tests are performed to assess the activity of the underlying connective tissue disease and to look for specific autoantibodies. While CTD-ILD is a broad term, the classification often depends on the underlying connective tissue disease causing it. So, we speak of rheumatoid arthritis, associated ILD, systemic sclerosis, associated ILD, and so on. Furthermore, within each of these, there can be different patterns of lung injury seen on HRCT and biopsy, such as usual interstitial pneumonia (UIP), non-specific interstitial pneumonias and SIP, or organizing pneumonia (OP). Identifying the specific pattern can influence treatment decisions and provide some insight into prognosis. Unfortunately, there's no cure for CTD-ILD currently. Treatment focuses on managing the symptoms, slowing the progression of the disease, and improving quality of life. Immunosuppressant medications, such as corticosteroids and other drugs that suppress the immune system, are often used to reduce inflammation in the lungs. Anti-fibrotic medications can help to slow down the progression of scarring. Pulmonary rehabilitation, which includes exercise training, breathing techniques, and education, can help patients manage their symptoms and improve their functional capacity. Oxygen therapy may be necessary for those with significant shortness of breath. In severe cases, lung transplantation may be considered as a last resort. Unfortunately, there are no proven methods to directly prevent CTD-ILD. However, managing the underlying connective tissue disease effectively may reduce the risk or slow the progression of lung involvement. This includes adherence to prescribed medications, regular monitoring by a rheumatologist, and lifestyle modifications such as avoiding smoking. The prognosis for CTD-ILD varies considerably depending on the underlying connective tissue disease, the extent of lung involvement, the specific pattern of lung injury, and the individual's response to treatment. Some patients may experience a relatively slow progression of the disease, while others may have a more rapid decline in lung function. Recent research is focusing on identifying biomarkers that can predict disease progression and response to treatment. Additionally, clinical trials are investigating new therapies, including novel anti-fibrotic agents and targeted immunotherapies. These advances offer hope for improving the outcomes for patients with CTD-ILD.